Good morning. Welcome to the November DUR. Thank you for coming to a different day than our usual meeting. A few reminder for our meeting today. If you are dialing in via telephone, Google Hangout has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. If you're using your laptop for audio and visual during the meeting, you can control the mute function on the Hangout. We kindly ask that only those who are speaking to the group unmute their device. DUR board member, please preserve the question until the end of the presentation or may ask in the Google Hangout meeting chat. For public comment, if you would like to provide a public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the DUR board, please enter your contact information in the Google Meet or email medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And Eric, I will leave the rest to you.
All right. Welcome to everyone to today's DUR board meeting. Bear with me this first time because I'll probably make a few mistakes here. But anyway, we'll call to order the DUR board for the state of Utah now. We do have a quorum, and so just welcome everyone. First order of business today would be to review the minutes, and then if we have a motion to approve. So I think the minutes went out earlier in the week. Are there any questions, things that maybe need to be corrected?
It looks like Kumar wants to say something. I think he's muted.
May I propose that we accept the drafted minutes as drafted?
All right, do we have a second?
Second.
Judith, thank you. All right, all in favor?
Aye.
Aye.
All right, the board minutes have been approved and passed. So Brian, I think we roll it over to you now for a P&T update.
Thanks, Eric. So next week we'll be meeting in P&T committee and we'll be reviewing antiretroviral combinations, primarily the single tablet regimens. And also we've completed our annual internal review of the preferred drug list and making preparations for that to go live at the first of the year.
Great. Thank you. So with that, I think we're going to move on and talk about cystic fibrosis. We've got Jeff Zobel with us. Jeff is a pharmacist up at Primary Children's Hospital. So excited to have him with us. He knows a tremendous amount about cystic fibrosis. So Jeff, it's all yours.
Okay, thank you. Well, thank you for having me present this morning. So last week we just had the North American Cystic Fibrosis Conference, and they gave us some good information about the new CFTR modulators, kind of the pipeline where it's going, but kind of study updates on elexacaftor, tezacaftor, ivacaftor from some studies that they've been doing, one called the Simplify trial, one called the Promise study, where they've been collecting information on what this medication is actually doing in the body for patients. So in just from a summary of those results, that they're seeing the new median lifespan for a CF patient right now is 59 years of age. It's the first time it's climbed 10 years in 2 years. I mean, in a 4 year, kind of they do 4 year gaps. It went from 49 to 59 since the last time they updated it. So a 10-year improvement in median survival in just one reporting cycle of that. They're seeing the first time that lung transplantation is the lowest it's ever been in the history of cystic fibrosis. It clears bacteria. They're starting to see the patients, upon initiation of these medications, they clear Pseudomonas, they clear stenotrophomonas and staph aureus initially in the first several months, and they don't grow it again. The number of adult patients now is 60% of the entire population is now adult versus pediatrics. So just good overall results. I mean, we're just seeing more and more that we're seeing coming out, just very effective. From our patient populations, we have very low admission rates. In now, when a time when Primary Children's is having a bed crunch and also staffing crunch, we only have one cystic fibrosis patient in right now, and that's a late diagnosis 8-year-old out of Idaho that wasn't because of any admission, but he was just late diagnosis. So that's the only admission we have right now. We've had maybe about a total of 15 admissions, 20 admissions this year total in 2021, which is, we normally have about 120, and we have about 20 admissions. That is just incredible to hear, to see. And our lung functions are the highest they've ever been. They're starting to see uptick in lung functions. I've got graphs that I can send you. They were actually from the CF Foundation. If you want me to put on the screen, I can share those if you'd like. Do you want me to do that? Just to kind of, there's one graph I can share.
Yeah, I think that'd be good, Jeff. Thank
just
you.
so you can see. These are from the CF Foundation. Just to share that, let me see if I can get this to work. You see these? So you can see that the survivability has gone up to 59. These are just some snippets that they shared at one of the CF one of the breakout sessions. Number of adult patients is 57 versus pediatric is now 42% of the population. This is what I was talking about, the uptick in FEV1. This is by age. So you can see the younger patients are now, they're stabilizing, being on these modulator therapies. These patients, some of them can be on it, some cannot, because now down to age 6. So this is just barely starting that age group being able to be on those therapies. But these are their older patients. This is the first time ever you're seeing an uptick in lung function in these patients, which is incredible. If you are a provider who's ever taken care of a CF patient, Dr. Britton is taking care of a lot of CF patients. This is incredible to see, especially in the adult population, where the adult center is seeing the same thing we are. Number of lung transplantations was a dramatic drop in lung transplant where it was stable, and all of a sudden 2020 it was less than 100 for the first time ever in the history of cystic fibrosis. And then the last thing they wanted to this is the bacteria. The clearing of the bacteria is probably the biggest thing that we are seeing with this. And so this medication does work. And I just wanted to tell you that it does work, and we have data now to show that. So I now will, from our data, we're seeing good results with the 6 to 11 now. They are studied down to age 2. Hopefully within the next couple of years, it'll be out down to age 2, and then we'll be able to see even bigger trends throughout the population. So I'll now leave it up to any questions that you guys have.
Hi, Jeff. Hey, it's Jen.
Yeah.
Thank you so much for bringing the latest data to us that you share your experiences. Couple questions. First of all, this was more like large population data that you've seen. Could you share your personal experience with what you're observing with local trends? And then secondly, other organ function aside from lung function, okay. Are you seeing other organ benefits as well?
So, I mean, we did, I got a actual poster that we did at the CF meeting that I presented. This is our data from Primary Children's. You want to see this. So this is, we looked at non-lung function, other things outside of lung function. So this is like antibiotics, that are being prescribed pre-post ETI, which is Trikafta, in the year, and this comparing it to using stratifying by other modulators. You can see that our oral antibiotic rates went from 189 down to 28 in a year, the year pre-post. Our admissions went from 65 down to 3. Body mass index, which would be attributed to nutrition, so this is nutrition, the improvement in BMI from over 2 kilograms, which is incredible for a CF patient. I mean, that's almost 6 pounds when you talk about it as an overall whole. And then doing their other therapies, we actually saw a drop in their other therapies, and they're seeing this in the simplified trial, actually studying this. And we actually saw in our patient population that they're reducing their therapies of other mucolytic therapies because their lung function is so good. So another experience beyond just information that we have, we've got from the gastrointestinal standpoint, all of our patients seem are now be going on diets, not the CF diet. They're actually going on a regular diet. We have obese CF patients now, which is incredible and almost impossible to think about, where you actually have to put them on a low-fat diet and tell them to only eat their high fat with their medication, because you got to take fat with the medication, but otherwise they're going on basically high healthy fat like avocados, olive oil, exercise. I mean, these are things because now they can exercise because they feel better. There's a CF baby boom. That's the one thing they actually said. Right now, the number of babies born to CF moms doubled in a year and a half. And now we're seeing CF babies born to CF moms who are now newborn screen negative and are pancreatic sufficient because they're actually on Trikafta, and it goes through the placenta and goes through the breast milk. There's actually case reports now of CF babies born to CF moms, and they're now almost disease free. And the only way to know is if you do the genetics. That's because it passes through the breast milk and the placenta. So there are a lot of sessions about that. But from the GI standpoint, backing off enzymes, patients who are they're now seeing it prevent CFRD, cystic fibrosis diabetes. If you give it, it actually turns on their pancreas, and we're starting to see patients go off enzymes. So it's an overall paradigm shift for a provider. Now we're talking all the things we knew about CF. Now we're starting to see the opposite, where they're going to live a lot longer than we've ever thought before because of this being on medications that are very effective. Patients are happy. Let's just say that they come in and it's a clinic is a joy. They blow their lung function, they do their PFTs, and they come back like with it used to take 20-30 minutes to get them to do it. They do it in about 2. They come back and their PFTs are high if they've ever been, and it's almost like a well child visit.
So Jeff, as these patients age and as they get older, I mean, we're talking about a jump of 10 years here in a very short period of time. What do we know about the sequelae of the disease as they get older that may not have borne out in the past because they never lived that long?
Right. That's what we don't know. That's what they're trying to study. So they have a thing called the PROMISE study, which is actually going through multiple different parts of the body. They're taking biomarkers, they're doing all these different things to try and see what is this going to do to the overall longevity of our CF patient. But I think we're going to start seeing as the adult population shifts more to an adult disease. It doesn't mean you won't have pediatric CF patients. It just means they'll age and your actual percentage of patients will actually start to grow. You'll actually have a larger, longer living population. You'll start to see old age type diseases, right? I mean, type 2 diabetes, osteoporosis. So those are the things they're starting to look at, and they're trying to tell us, hey, we may need to start measuring lipid fat panels, cholesterol levels, things that we didn't even think about years ago. Now we're going to have to start thinking about this as we trend them to the adults population, more adult type conditions as they live longer.
So maybe a follow-on question to that, as they transition into adulthood, I think everyone's been fairly comfortable and knowledgeable in terms of cystic fibrosis in kids. What are the barriers you guys are seeing now to treatment as people kind of transition past that pediatric stage into adulthood?
One of the things is because before they would qualify for disability, Medicaid, SSI because they couldn't work. Now they're able to work. They have insurance issues they're having on the adult side. They're having getting jobs because now they're like, okay, I'm now going to go get college. I'm going to work. And so now we're having to prepare the families and the kid, as they transition. You're no longer going to have to worry. You're not going to be doing this. You're going to be more focusing on getting a career, focusing, shifting that focus to living longer as opposed to being disabled. So a lot of the adult centers are having issues where before they would, they couldn't, they get disability Medicaid because they couldn't work. Well, now they're off oxygen, they have energy, and now they're having to figure out how to do it because before they weren't. Now it's a dramatic shift. So that's a big thing that the adult centers are dealing with.
Right. Thank you.
So I think
go ahead, Jeff.
I think Jen Britton had her hand raised.
I can see it. Yeah, Jen, go ahead.
Yeah, thanks. Sorry, we're in a dark room right now. This has just been so fantastic, you guys, and I'm excited that now CF patients can have the same challenges and diseases that adults have that don't have CF. I think this is just fantastic. You don't know, I mean, when these kids would come in the hospital, it wasn't like an overnight stay. They'd be there 2 weeks getting lung cleanouts. They'd be so sick. They'd miss school. They wouldn't go back in a very healthy way. And then once this happened, the two kids I had in private practice, they did have they were able to get the therapies, and just seeing the change in their lives and their optimism and what they could do and their knowledge of their potential. It's just been amazing. I'll tell you, psychiatrically, medically, this has been so huge. I'm just so grateful to have this. And, we hold out hope for our other diseases too. I'm like, okay, these other diseases, like maybe you'll have a CF outcome too. So this is such a great thing. I'm glad that in the past, our group has supported doing the therapies and keeping this up. So thanks so much.
Can't find
Hey,
the
Jeff,
Go ahead, Joe.
Jeff, it's Joe with the state of Utah. Hey, right now we ask for prescribers of these drugs to be. We ask that these patients be managed in a CF clinic, and I assume, but I want to get your opinion. Is that still an appropriate PA criteria?
Yes, I believe yes, because I mean, the monitoring of this, we have to do every 3-month liver function tests. We are seeing, it was mentioned in several of the sessions because it does go through the liver, and there are some individuals who they have issues with their liver, and so we want to make sure we're monitoring appropriately. Eye exams are being done. So if it's being managed by a non-CF provider, it's probably not the appropriate way to do it. So yes, I would say keep that as a PA criteria that we see at a CF center.
Kumar?
Just one issue comes to my mind. Are we sharing and educating minority community with respect to these new findings and new medications?
If they are seen at the CF center, then yes, because but cystic fibrosis is such a rare disease outside of the Caucasian population. We only have a few Hispanic patients who are eligible for it. Most of their mutations in the Hispanic population are the class 1 or X mutations, stop codon mutations. So they don't qualify for this medication. There actually is a new med coming in the pipeline that's just started phase 3 clinical trials called ELOX-02, which actually hits the G542X mutation, which is the most common in the Hispanic population. And that will probably be coming out. And when that comes out, then they'll have a medication. But most of the CF population that do qualify for this medication are Caucasian. And so, and they're seen in our centers, so we educate them about it.
Right. What about African Americans?
we have one African American in our population is actually 1/4 African American. That's the only one in our population. So we have because again, cystic fibrosis does not usually happen in the African American population just by genetics. It's just the way it stratifies in where you see the mutations. It's usually in a Caucasian population.
Thank you.
No problem.
All right. Seeing no other questions, thank you, Jeff. We really appreciate that. The pharmacy team's now going to review some utilization data and the prior authorization criteria with us. So I'm not sure who's got that one, but we'll turn it back over to them.
Thank you, Eric. So this is the data utilization that we pull from not just fee-for-service, but also from the ACO itself, just to see where the utilization mostly lay on with these therapy. So this is pulling from November of last year until November of this year. For Calideco, we have 1 unique patient, while the ACO have 5 unique patients. The Orkambi, we don't have any with fee-for-service. ACO have 1 unique patient. Symdeko, similar to Orkambi, ACO have 1 unique patient. But as Jeff saying, the most utilization is lying with Trikafta. Fee-for-service have 1 unique patient, and the ACO have 40 unique patient that is using the Trikafta right now. Any questions with the utilization review?
No, I can't think of any. Does anybody else in the group have any questions? All right, hearing none, we can move on.
Thank you.
All right, are we reviewing the PA criteria?
My apology. I know we don't review PA criteria. We're keeping the PA as it is.
Okay, all right, good. I missed that a little bit. So we will now turn it over to whomever is speaking to House Bill 178 and pharmacist prescribing.
Hi, hey, Jen Strohecker here, and Dr. Hoffman, if you're on, perhaps you can give a few updates as well from your perspective with regard to the work on House Bill 178. So, and we've discussed this several times that Medicaid will adopt the programming and the changes and the rule language around House Bill 178, which authorizes pharmacists to act as Medicaid providers effective January 1st of this year. With that, Medicaid as well, so fee-for-service as well as the 4 ACOs are programming their systems to be able to recognize, first of all, a pharmacist as a billable prescriber. Now, there is no, as a prescriber, so actually not a billable prescriber, but as a prescriber. So it'll be an ordering and referring prescriber. There is no money tied to this bill, so they won't be reimbursed for the duties. But the pharmacist will be able to prescribe medicines and put claims through the system. With this bill, there are 4 classes of medicines that have been designated as meeting a public health need. And those will be, first of all, naloxone. Second would be HIV PrEP and PEP. Third would be self-administered oral contraceptives or contraceptive devices. And then the fourth will be smoking cessation products. With these pharmacists, as it's defined in the rule that is being put together by DOPL right now and ready actually to go out for public comment shortly. With this, it will be defined the roles and responsibilities of pharmacists. But the update for this group really is that Medicaid will be a participant in this, and we will have our systems and programming ready by January 1st for the go live date. And we've been working holistically with our programming within the pharmacy system, our Medicaid system, as well as our point of sale vendor, as well as our ACO partners, to make sure that we are ready to implement this when it goes live. In addition to this, the Department of Health has had an important role in the development of this, and also ongoing responsibility and a role in implementing this over time. This is something, Dr. Hoffman, are you still on? Would you be able to speak to it?
Yeah, I'm here.
Yeah, that'd be great.
Yeah, we've been
Oh,
at
hi.
this since the end of the last session, and it's been a fairly iterative process. A lot of the work came through the pharmacy board at DOPL. The Department of Health has a group of subject matter experts from the different areas of public health concern where we are going to begin prescribing by pharmacists. And then the department will play an ongoing gatekeeping role in terms of identifying future public health needs that may be served by pharmacists, expanding their prescribing. And so it'll be their job to identify other public health needs that may be served in a similar way. And so we're looking forward to the ongoing collaboration with DOPL and with pharmacists to help support closing some of the access gaps that we know are very real for patients. When there's very clear rules around referrals, scope of practice, communication, closed loop communication with primary care physicians that are required as a result of being the prescriber. And then DOPL created guidances that are fairly detailed in terms of the actual clinical practice for each of these areas. So it was a very thoughtful process, and we're excited to see that work move forward.
So Jan, one quick question on this. In the past, with Medicaid and the ACOs, we only cover prescriptions that were prescribed by someone that's on the known provider file.
Mm-hmm.
Since there will be no contract between the department and these pharmacists, how will that be handled?
Actually, it's a really good question, Eric. So that is some of the prep work we've been doing, is that pharmacists will have to enroll as Medicaid providers so that they are actually enrolled in the system, and they're when they prescribe, the claim can process through the system, tagged as the pharmacist as the prescriber. So there's been a provider type 61 in our system that was specifically developed for pharmacists. And since there's a partner bill that was also released earlier this year for physician assistants, for example, there was a provider type for physician assistants that was developed specifically this year. We're also working on one for dental hygienists, as they now have new prescriptive authority as of next year, right? So, for example, if we go back to pharmacists, in order to be a recognized Medicaid provider, they actually need to enroll with Medicaid and then go through that process that any prescriber would. And then with that, they would be known to our system and then would be able to process the claim.
So are there specific requirements in terms of education or knowledge base or anything else, or could I do it? Can I go online and fill out a form?
Yeah, I mean, I'm not part of the provider enrollment team, but I know it is a fairly robust process that does background checks and looks at licensure to ensure that your license is active and in good standing. And that's part of our provider enrollment team that reviews those requests. And I believe it's like a multi-step process that an individual needs to go through to become enrolled as a Medicaid provider. And then with that, of course, you then have the ability to do that. As far as you, Eric, if you have if you want to go through the process and if you want to enroll and you have a license, yes, you could. I mean, there aren't, and this was discussed with the Board of Pharmacy, Dr. Hoffman, myself, are there certain certification requirements that a pharmacist must have in order to participate and be eligible to do this? And it was pretty clear that pharmacists would use their clinical judgment to determine whether or not they should be prescribing these, and based on their training and their knowledge, that there weren't, that would be the basis that someone would be allowed to act as a prescriber for these, and that there wasn't a certain amount of extra training or CE aside from the self-administered contraceptives. There wasn't a special training requirement in order to be a prescriber of the defined classes. So,
Eric, you might want to get that record expunged before you apply. Just throwing that out there.
Yeah, ever since the incident. Anyway, no, and because
the one thing I will say is we did program our system to limit what pharmacists could prescribe. So we did limit by like a GPI classification. So if a pharmacist were to attempt to prescribe, something else that's outside of those defined classes, the claim should reject. It wouldn't process.
Okay. Well, and due to my concern for public safety, I won't be prescribing anything. So, with that, early refill policy. And I apologize for my dogs. They just found new friends, I guess.
Hi, everyone. So I'm just going to be updating everyone on a change to our early refill policy today. So previously, we would have calls come in from pharmacies. They would tell us about the patient's situation and the patient's medication that they needed an early refill on, whether that was lost stolen medications, someone dropped the bottle and it broke and it was a liquid, that kind of thing. Based on our old policy, we were only able to override these based on life-saving necessity. And the issue with that were these 3 bullet points. So some of these cases were really complicated, and it took time for the pharmacist to come to a consensus on whether it was life-saving or not. It usually only allowed overrides in extreme circumstances. Some common examples were epilepsy, especially in kids, patients who had poor mental health and were in and out of the hospital or suicidal. And then this policy didn't account for patients who were at risk for being seriously acutely ill, even if it might not be considered a life-saving situation. So our change that we implemented as of November 1st is that we will evaluate it based on medical necessity. So the intention of this is to expand that so that way we can cover those patients who either who are at a higher risk of becoming acutely ill. So this part below is our full definition of medical necessity based on Medicaid's provider manual. And not the highlighted, but the bolded part is the part that really applies to this policy here. So it reads, a service is considered medically necessary if it is reasonably calculated to prevent, diagnose, or cure conditions in the member that endanger life, so it includes the life-saving aspect of it, causes suffering or pain, causes physical deformity or malfunction, or threaten to cause disability. So this will expand to include things like multiple sclerosis, Parkinson's disease, things that progress if the patient's not on the medication, and really just opens access to patients who, if they need an early refill or have a lost stolen medication, really can't a lot of times afford to replace it since they're usually lower income. Does anyone have any questions on the new policy?
No, thanks. That makes sense. I know we run into this a lot where it's surprising how many people open their medication over the sink or the toilet. But anyway, this is a good thing for you guys to do. So thank you. Any questions from the board on this? All right. Seeing none, acute hereditary angioedema. We have that coming up next.
Thank you. So yeah, we will go over the acute hereditary angioedema. So the objective of today's review is to understand the pathophysiology of HAE. We will review the available treatment of acute today, and the University of Utah, the DRRC, will review the prophylaxis treatment at the next DUR meeting. Also, the recommendation on HAE prioritization and policy will also be bringing up at next DUR meeting. So regarding the pathophysiology of the HAE, it is a rare autosomal dominant inherited genetic disorder. There are most two common types that affected the mutation in the gene that encoded the C1 inhibitor. Type 1 is accommodate for like 85% of the case where patients have the deficiency of the C1 inhibitor level. The type 2 is less common, is only 15% of the case where patients have the normal level of the C1 inhibitor, but the protein is just not functioning correctly. Before, there was a terminology called for the type 3, but according to the new guidelines, that term is discouraged and is just called as a patient who have normal C1 level and functioning, but however, they have the mutation like affecting the coagulation factor 12, plasminogen, or kininogen that affecting the cascade. We will take a look at the cascades in a couple slides. The patient will present with this disease where they have the recurrent angioedema, where they have episodes of the accumulation of fluid outside of the blood vessel that end up blocking the normal blood flow or lymphatic fluid flow. Patient will have rapid swelling of tissues in the hand, feet, lymph phase, intestinal tract, or the airway. But all of these swelling is happen without urticaria. They don't have hive, different from allergic angioedema. These will result in 3 to 5 days. If the provider suspect the patient have the HAE, they can confirm by order the lab level of the C4. Since this patient can have swelling in the airway, it can be life-threatening. There's no unpredictable trigger to the HAE. Patient can have HAE after physical trauma, surgical infection, emotional distress, medication, or even hormone influence like estrogen. These HAE doesn't respond to antihistamine, corticosteroid, or even epinephrine. It is different from the allergic swelling with hive. Looking at these downstream pathophysiology, we can see that the bradykinin, the increasing in the bradykinin at this step, leading to binding to the beta-2 bradykinin receptor, causing the vasodilation, increasing in permeability and edema. It all going down from when the coagulation factor 12 converting into activated and activated the whole cascade where the precalagrin going causing the production of calagrin, creating the production of high molecular weight kininogen, increasing in level of bradykinin. Bradykinin can be degraded by the ACE. However, that sometimes can be blocked by ACE inhibitor, as we well know that ACE inhibitor can causing angioedema. Icatibant is a medication that can block the bradykinin beta-2 receptor, as well as the ecallantide medication that can block the production of calagrin. And the supplement of C1 inhibitor can blocking the conversion from precalagrin to calagrin, and also the downstream cascades. For the prevalence of this disease, it affected males and females in similar way. Symptoms can begin in early childhood. There is about 1 over 50,000 of people affected by this disorder worldwide, estimated of about 6,000 people affected in the US. For the acute treatment, up until 2009, there was no FDA-approved therapy for acute attack. Most of the patients who having the acute attack will be treated with the supportive therapy only. If they are having like the GI attack, they will be supported by giving medication for the relief of pain and nausea or fluid replacement. If they're having an attack in the oropharyngeal attack, they need to be intubated as needed or even tracheostomy. Back then, fresh frozen plasma can be used. However, there was a caution with that because that's not just giving the C1 inhibitor, but also giving more factor 12, precalligrin, and kininogen in the fresh frozen plasma, which will make more bradykinin before stopping the production of bradykinin. So patient will get worse before they're getting better. According to the 2020 HAE guideline, recommended patient to have a ready access to effective on-demand medication at an onset of an HAE attack. With the first line is the FDA-approved medication that patient can self-administer or administered by a caregiver. There is 4 medication that's got approved for the acute treatment of HAE. First of all is the Berinert. It's approved in 2009. It is a plasma-derived C1 esterase inhibitor. It's approved for pediatric and adult. It's giving intravenous only at 20 international units per kilogram. Even though it is IV giving, patient can also self-administer at home at an onset of an attack. Calbitor, a generic name of ecallantide, is also approved in 2009. It inhibits the kallikrein in the cascade that we will show earlier. It's approved 12 years and older. It's giving subcutaneously at 30 milligrams. Even though this is subcutaneous, it can only be given by the healthcare provider. Patient cannot self-administer this medication. Fiprazir is approved in 2011. It inhibits the bradykinin beta-2 receptor, one step before the edema happens. It is approved 18 years and older, also giving in subcutaneous at 30 milligrams. Patient can self-administer Fiprazir. Ruconest is a recombinant C1 esterase inhibitor approved in 2014, approved for adolescents and adults. It's also giving IV only at the max dose of 4,200 units. Patient can also self-administer for the IV. For the Berinert and the Ruconest, on their website, they have the instruction for how patient can self-administer at home. Looking at the clinical study of these medication, for quick, it is Berinert is having they met the primary outcome of having the shorter time to relief versus the placebo at 48 minutes rather than placebo at 4 hours. Calbitor have 143 participants. They met the primary endpoint of demonstrate a greater improvement in symptom severity from baseline versus the placebo at 4 hours. Fiprazir they met the primary endpoint of having 50% reduction in severity at 2 hours versus the placebo at 20 hours. Ruconest also met the primary endpoint of having the symptom relief at 90 minutes versus the placebo at 52 minutes. So the medication have a quicker onset of medication in a quicker onset of symptom in about 30 to 60 minutes. Looking at the utilization for these medication, I pull the utilizations in the year that is approved. So for Berinert, we don't have any patient. For Calbitor, we have 1 unit patient back in 2020. Fiprazir, we have 2 unit patient in 2019. But Ruconest, we don't have any utilization at all. So this medication is really little utilization for us. And that is conduct the acute HAE for this presentation. Any question?
So limited number of people using this, and, you know, or have you limited this to acute use, or does this also include patients using this for prophylaxis?
Yes, Eric. So this is only for acute uses for the medication. We will review the prophy at next DUR meeting.
Okay. All
And we
right.
will also,
Thank you.
yeah, we will also present the utilization for the prophylaxis, but we're probably with also the ACO claim as well.
All right. Any questions from the board? All right. Seeing none, a big thank you to Jeff Sobel and all of the pharmacy team at the department. Thank you. Very informative information today. So our next meeting is Thursday, December 9th. So coming up, I guess, here in a month. And with that, if we have a motion to adjourn, we can all move on and have a happy day.
Motion to adjourn.
We have a second? Kumar, we're out of here. All right, guys. Hey, thank you.
Thanks, everyone.
Thank you.
Bye-bye.
Bye-bye.
Thank you.
Thanks. Bye-bye.
Bye.